Principles of the Perfect Sleeve Gastrectomy, adapted from Michel Gagner's International Sleeve Consensus Conferences and the Perfect Sleeve Gastrectomy, updated with the 2025 Consensus. The Principles of the Perfect Sleeve Gastrectomy. Michel Gagner Concept, updated 2025. 1. Complete fundus excision. Completely mobilize the gastric fundus. Divide all short gastric vessels and posterior attachments. Fully expose the left diaphragmatic crus. Excise the entire anterior and posterior fundus to prevent a residual fundus, neofundus, which predisposes to weight regain and persistent hunger. 2. Appropriate sleeve calibration. Fashion the sleeve over a 36 to 40 fr bougie. Avoid excessively narrow sleeves because they increase the risk of leaks and strictures without improving long-term weight loss. 3. Preserve the functional antrum. Begin gastric transection 4 to 6 cm proximal to the pylorus. Preserve adequate antral volume to maintain gastric emptying and reduce intraluminal pressure. 4. Construct a straight, uniform gastric tube. Create a symmetric sleeve with a constant diameter from the antrum to the gastroesophageal junction. Avoid twisting, spiraling, corkscrew configuration, kinking, or hourglass deformity. 5. Preserve the incisura angularis. Avoid narrowing at the incisura. Functional stenosis at this level increases intragastric pressure and is a major cause of proximal staple line leaks and dysphagia. 6. Perform a safe and meticulous staple line construction. Choose staple height according to gastric wall thickness. Allow adequate tissue compression before firing. Avoid crossing staple lines near the gastroesophageal junction. Staple line reinforcement or oversewing may be used according to surgeon preference and patient characteristics. 7. Preserve blood supply and tissue perfusion. Handle tissues gently. Avoid excessive traction and thermal injury. Maintain excellent vascularity of the proximal sleeve, particularly near the angle of his, where ischemia contributes to leaks. 8. Preserve the gastroesophageal junction anti-reflux mechanism. Achieve complete fundus excision while preserving the normal anatomy of the gastroesophageal junction whenever possible. Avoid unnecessary disruption of the phrenoesophageal ligament. Maintain at least a 1 cm distance from the angle of his during the final staple firing. Repair any associated hiatal hernia. These technical principles reduce sleeve migration, proximal sleeve deformity, postoperative gastroesophageal reflux, and Barrett's esophagus risk. What has changed in the recent revisions, 2025 to 2026? Compared with earlier consensus statements, the recent conferences place greater emphasis on 1. Reducing postoperative reflux, rather than focusing only on weight loss. 2. Selective rather than routine hiatal dissection. 3. Repairing small hiatal hernias when identified intraoperatively. 4. Maintaining at least a 1 cm distance from the angle of his. 5. Long-term endoscopic surveillance because of the risk of Barrett's esophagus after sleeve gastrectomy. 6. Revision to Roux-en-Y gastric bypass as the preferred revisional procedure for severe reflux after sleeve gastrectomy. The goal of sleeve gastrectomy is not merely to create a narrow stomach, but to construct the perfect sleeve, a well-calibrated, anatomically sound, and physiologically functional gastric tube that provides durable weight loss while minimizing complications such as leaks, strictures, weight regain, sleeve migration, and postoperative gastroesophageal reflux. This illustration demonstrates the patient's position, the surgical team arrangement, and the optimal trocar, port, placement for the procedure. Operative steps of laparoscopic sleeve gastrectomy. Step 1. Greater curvature mobilization. The procedure begins with mobilization of the greater curvature approximately 4 to 6 cm proximal to the pylorus, preserving the functional antrum. Using an advanced energy device, the greater omentum is divided close to the gastric wall while preserving the gastroepiploic arcade. The dissection proceeds cephalad toward the angle of his with sequential division of the short gastric vessels and complete release of all posterior fundal attachments. Special attention is directed to complete mobilization of the posterior fundus and full exposure of the left diaphragmatic crus. This critical step ensures complete fundus excision, prevents residual fundus formation, facilitates proper sleeve orientation, and allows accurate identification of any associated hiatal hernia. Step 2. Sleeve creation and stapling. A 36 to 40 French calibration bougie is introduced along the lesser curvature to guide gastric transection. Stapling is initiated 4 to 6 cm proximal to the pylorus, preserving adequate antral function while creating a straight, uniformly calibrated gastric tube. Staple cartridge selection is based on gastric wall thickness, extra thick antrum, black cartridge. Thick gastric body, green cartridge. Intermediate body, gold cartridge. Thin proximal fundus, blue cartridge. Adequate tissue compression is allowed before each firing to optimize staple formation and tissue perfusion. Sequential firings are performed parallel to the bougie while avoiding narrowing at the incisura angularis and excessive medialization near the gastroesophageal junction. The final staple firing is completed approximately 1 cm lateral to the angle of his, ensuring complete fundus resection while preserving the anatomy of the gastroesophageal junction and reducing the risks of ischemia, leak, and postoperative reflux. Step 3. Staple line reinforcement. The entire staple line is reinforced with a continuous seromuscular invaginating suture using an absorbable suture. Staple line reinforcement offers several potential advantages: improves staple line hemostasis, reduces postoperative bleeding, decreases mechanical tension along the staple line, provides additional support during the early healing phase, may reduce the incidence of staple line leakage in selected patients, produces a smoother, more uniform gastric tube. Although reinforcement techniques remain surgeon-dependent, meticulous tissue handling remains the most important determinant of staple line integrity. Step 4. Gastropexy to the prepancreatic fascia and greater omentum. Following sleeve construction, the gastric tube is secured to the prepancreatic fascia and reattached to the remaining greater omentum with interrupted absorbable sutures. This gastropexy provides several important benefits: maintains the sleeve in its anatomical position, prevents axial rotation and twisting, reduces sleeve kinking, decreases the risk of proximal sleeve migration, minimizes internal herniation of the gastric tube, helps maintain a straight, tension-free sleeve configuration, may contribute to reducing postoperative gastroesophageal reflux. The resected stomach is placed in a protective retrieval bag and extracted through the enlarged 12 or 15 mm trocar site, avoiding direct contact with the wound edges. The facial defect at the extraction site is closed securely to prevent trocar site hernia, followed by routine skin closure. The completed operation results in a straight, uniformly calibrated, well-vascularized gastric sleeve with complete fundus excision, preserved antral function, secure staple line reinforcement, stable anatomical fixation, and restoration of the gastroesophageal junction when indicated, adhering to the contemporary principles of the perfect sleeve gastrectomy.